What if the blood pressure number you have been praised for is not the safest number for the body you have today? Imagine this. You sit in the exam room. The cuff tightens around your arm. The machine beeps. Your doctor looks at the screen and says, "Excellent, 118/72. You feel relieved because that is the number you were taught to respect. Lower is better, perfect is safer, 120/80 is the gold standard. But then you go home and your real life tells a different story. You stand up in the morning and feel a wave of dizziness. You walk to the bathroom and hold the wall for balance. Your head feels foggy until breakfast. Your legs feel strangely weak, even though your blood pressure chart looks beautiful. You mention it once, maybe twice, and someone says, "That can happen with age." But what if it is not simply age? What if the number that looks perfect on paper is too low for your circulation when you stand, walk, shower, or move through a normal day at 73, 78, or 85? And today I want to talk about a mistake that can happen quietly in older adults. Chasing a blood pressure number without asking whether that number is actually working for the person living inside the body. Let me be clear right away. High blood pressure is dangerous. Uncontrolled hypertension can raise the risk of stroke, heart failure, kidney disease, and heart attack. Nobody should ignore it. Nobody should stop medication because of a video, and nobody should decide on a target without their own doctor. But the opposite problem also matters. Blood pressure that is pushed too low, especially in an older person with symptoms, can create dizziness, weakness, falls, and poor quality of life. The goal is not the lowest possible number. The goal is the safest, useful number for you. That is the conversation too many people never have. Before we go further, let us separate the two numbers because many viewers focus only on the top one. The top number, systolic pressure, reflects the force when the heart squeezes. The bottom number, diastolic pressure, reflects the pressure when the heart relaxes between beats. In older adults, systolic pressure often rises while diastolic pressure may fall because stiff arteries do not behave like flexible young vessels. That creates a wider gap between the two numbers, sometimes called pulse pressure. A very low bottom number can matter too, especially if someone has coronary artery disease, because the heart muscle receives much of its own blood flow during the relaxation phase. This is another reason older adults need individualized interpretation instead of a single slogan. Also understand this. Blood pressure is not one fixed number. It is a moving signal. It changes when you stand, eat, sleep, worry, exercise, drink coffee, take medicine, become dehydrated, or walk into a clinic. A reading at 10 in the morning while sitting quietly may not represent what happens at 2 in the morning when you stand up quickly. It may not represent what happens after lunch when blood shifts toward the digestive system. It may not represent what happens after a hot shower when blood vessels relax. Older adults often live in those transitions, and those transitions are where symptoms appear. This is why the word perfect can be misleading. Perfect in what position? Perfect at what time? Perfect before or after medication? Perfect with symptoms or without symptoms? Perfect for a person who has never fallen, or perfect for someone recovering from a hip fracture? These details are not small details. They are the difference between a number-centered plan and a patient-centered plan. For years, the public learned one simple message: 120/80 is normal, and anything higher should make you worried. That message helped many people take hypertension seriously. It probably prevented real harm. But bodies change with age, and medicine becomes dangerous when one simple rule is applied to every person in every situation. A healthy 45-year-old and a frail 86-year-old do not have the same circulation. Their arteries are not the same. Their balance is not the same. Their medication burden is not the same. Their fall risk is not the same. So why should they be treated as if the same number automatically means the same thing? After 60, many arteries gradually become stiffer. They do not cushion pressure waves as smoothly as younger arteries. The nervous system also becomes slower at adjusting pressure during position changes. When you rise from bed, gravity pulls blood toward the legs. In a younger body, pressure sensors in the blood vessels quickly tell the heart and vessels to adjust. Blood flow to the brain is protected before you even notice. In an older body, that response may be slower. If the resting pressure is already low because medication has pushed it down, there may be very little reserve. You stand, Pressure drops, your brain receives less blood for a few seconds, and you feel lightheaded, cloudy, or unsteady. Most people do not faint. That is why the problem gets ignored. They simply pause at the edge of the bed, they grip the sink, they wait for the room to settle, then they carry on, believing this is normal aging. But a repeated warning signal from your body deserves attention, especially if it began after a medication change or became worse as your blood pressure numbers became lower. Ask yourself this: do you feel dizzy when you stand? Do you feel weaker in the morning than later in the day? Do you sometimes feel as if your thinking takes longer to switch on? Have you ever stood up and seen the room darken for a second? Have you ever needed to hold furniture to steady yourself? If any of that sounds familiar, keep listening. The issue is not that blood pressure treatment is bad. It is that treatment must be individualized. Current medical thinking has moved toward personal targets, especially for older adults, people with frailty, people with a history of falls, and people taking several medications. Some active older adults tolerate lower targets well and benefit from them. Others feel worse, fall more, or develop symptoms when the same target is forced on them. That difference matters. A blood pressure number is not a trophy. It is a tool. A tool should help you live longer and function better. If the number looks excellent but you are dizzy, weak, falling, or mentally foggy, the number needs to be interpreted in context. Let me explain what actually happens during a low-pressure episode. Your brain depends on constant blood flow. It does not store oxygen the way some other tissues can. Even a brief reduction in flow can produce symptoms. You may feel lightheaded, blurred, slow, nauseated, sweaty, or suddenly unsure on your feet. These symptoms are your brain asking for better circulation, not your character failing and not your body being dramatic. Now imagine this happening at 2 a.m. You wake up to use the bathroom. The room is dark. You have been lying down for hours. You may be slightly dehydrated. You may have taken blood pressure medication, a water pill, a sleep medicine, or another drug that affects balance. You stand quickly. Your pressure drops. You take 3 steps before your brain fully adjusts. That is when falls happen. And after 75, a fall is not a small event. A fall can mean a wrist fracture, a hip fracture, a head injury, surgery, hospitalization, rehabilitation, fear of walking, loss of confidence, and sometimes loss of independence. This is why dizziness is not a minor complaint in an older adult. It is a safety issue. Many people think falls are random. Sometimes they are. A rug curls at the edge, a shoe slips, a step is missed. But many falls have a physiological trigger, and blood pressure is one of the triggers worth checking. The medical term you should know is orthostatic hypotension. Orthostatic means related to standing. Hypotension means low blood pressure. Together, it describes a meaningful drop in blood pressure after you stand up. This can happen because of dehydration, anemia, diabetes, Parkinson's disease, heart problems, long bed rest, alcohol, hot weather, or medication. Blood pressure pills can contribute. Diuretics can contribute. Some antidepressants, prostate medicines, sedatives, and pain medicines can contribute too. Often it is not one single cause. It is the combination. That is why you should not guess. You should measure. I want to teach you a simple home check. This does not diagnose you by itself, and it does not replace a clinic evaluation, but it gives you useful information to discuss with your doctor. Use a reliable home blood pressure monitor. Sit or lie quietly for 5 minutes. Do not talk. Do not scroll your phone. Let your body settle. Take your blood pressure and write down the top number and bottom number. Then stand up safely. If you are at risk of falling, have someone near you. Stand beside a bed, chair, or counter. Within 1 minute, take your blood pressure again if your monitor allows it, then take it again at about 3 minutes. Write down the numbers and write down symptoms. Did you feel dizzy? Did your vision dim? Did your legs feel weak? Did your heart race? Did you need to sit? A drop of about 20 points or more in the top number, or 10 points or more in the bottom number, within 3 minutes of standing is commonly used as a warning pattern for orthostatic hypotension. Even if the drop is smaller, symptoms still matter. Your doctor needs both the numbers and the story. Do this on more than one day, especially if your symptoms come and go. Morning readings can be different from afternoon readings. Readings after meals can be different from readings before meals. Readings after a hot shower can be different from readings during a cool, quiet morning. Bring the pattern, not just one number. And please do not make medication changes on your own. Stopping blood pressure medicine suddenly can be dangerous. Some medications must be tapered. Some people truly need intensive control because of their history. The goal is to start a smarter conversation, not to become your own pharmacist. Now let us talk about the doctor visit. Many patients walk into the clinic with symptoms and walk out with no answer because they do not ask the question directly. They say, "I feel tired," and the visit moves on. They say, "I get dizzy sometimes," and the symptom is dismissed because the office blood pressure looks fine. You need more precise language. Say this: "I am having dizziness when I stand. Can we check my blood pressure lying, sitting, and standing today?" That sentence matters. Then ask, "Given my age, my fall risk, and my symptoms, what is my individualized blood pressure target?" Do not ask only, "Is my blood pressure good?" Good for whom? Good in the office or good at home? Good while sitting or good after standing? Good for stroke prevention but bad for balance? Ask for the target that belongs to your actual situation. Then ask, "Could any of my medications be contributing to these symptoms?" This includes blood pressure medication, but not only blood pressure medication. Bring a full list. Include over-the-counter sleep aids, allergy pills, pain medicines, supplements, prostate medicines, and anything you take only sometimes. Your doctor cannot protect you from a medication they do not know you use. Now, some people watching this may be thinking, "My doctor will be annoyed if I ask these questions." A good clinician should not be annoyed by useful information. You are not demanding a specific answer. You are asking for a personalized assessment. That is appropriate. That is responsible. That is exactly what older adults need. There is another reason this conversation matters. Office readings can be misleading. Some people have white coat hypertension, where pressure rises in the clinic because they are anxious. Others have masked problems, where the office reading looks fine, but home readings show drops, spikes, or patterns the clinic never captures. One sitting measurement cannot explain your whole day. A home log can. For 1 week, record morning and evening blood pressure as your doctor recommends. Also record standing symptoms. Write down medication timing. If dizziness happens after breakfast, write that. If it happens after a shower, write that. If it happens after taking a diuretic, write that. Patterns are powerful. Your doctor can do much more with a pattern than with a vague complaint. Let me give you a practical example. A 79-year-old woman has a clinic pressure of 118/68. Everyone congratulates her. But at home, before breakfast, she is 116/65 lying down and 92/58 1 minute after standing. She feels dizzy and grips the dresser. Later in the day, she is fine. That clinic number is not the whole story. The standing number explains the symptom. Another example, an 82-year-old man has a sitting pressure of 138/76. He worries because he was told anything above 130 is dangerous. But he walks daily, has no dizziness, no falls, no kidney problems, and his doctor reviews his full risk profile. For him, the plan may be different from the woman who drops to 92 standing. Same age group, different body, different answer. That is personalized medicine. Now let us address a dangerous misunderstanding. This video is not telling you to accept uncontrolled high blood pressure. Numbers that stay very high, especially if they are repeatedly in the range your doctor considers unsafe, need medical attention. Severe headache, chest pain, shortness of breath, weakness on one side, confusion, trouble speaking, or vision loss are emergency warning signs. Do not sit at home with symptoms like that. High blood pressure can be silent and serious. Low blood pressure symptoms can also be serious. Mature health decisions hold both truths at the same time. The mistake is not treating hypertension. The mistake is treating a number while ignoring the patient. What should you watch for? Watch for dizziness on standing. Watch for new fatigue after medication changes. Watch for morning fog that improves later. Watch for falls or near falls. Watch for weakness after meals. Watch for symptoms after hot showers, alcohol, dehydration, or missed meals. Watch for a pulse that becomes very slow or very fast when symptoms occur, and watch the timeline. Did symptoms begin after a new medication, after a dose increase, after weight loss, after illness, after reduced appetite, after a hospital stay? A dose that was right for you 3 years ago may not be right today. Bodies change, weight changes, kidney function changes, activity changes, salt intake changes, hydration changes. The medication plan should be reviewed as life changes. There is another pattern worth knowing. Post-meal blood pressure drops. Some older adults feel sleepy, weak, dizzy, or foggy after eating, especially after a large meal or a meal heavy in refined carbohydrates. This can happen because more blood is directed toward digestion and the body must adjust circulation. If the adjustment is slow, pressure can fall. People often blame the food itself or assume they are simply tired after lunch. Sometimes the real issue is that the cardiovascular system is struggling to compensate. If you notice symptoms after meals, write that down too. Note what you ate, when symptoms started, and whether you were standing or walking. Your doctor may suggest smaller meals, hydration strategies, medication timing adjustments, or further evaluation, depending on your situation. Again, the point is not self-treatment. The point is better evidence for the person treating you. Hydration is another simple but powerful factor. Many seniors intentionally drink less because they fear nighttime urination or bladder accidents. Others lose thirst sensation with age. Some take diuretics. Some avoid fluids before appointments or trips. Low fluid intake can reduce blood volume, and low blood volume can worsen standing dizziness. But fluid advice must also be individualized. Someone with heart failure, kidney disease, or certain sodium problems may need specific limits. So do not force water blindly. Ask what fluid range is safe for you. Now let us talk about blood pressure medicines without demonizing them. These medications save lives. CE inhibitors, ARBs, calcium channel blockers, diuretics, beta blockers, and other medications can be exactly the right treatment for many people. The danger is not the medication itself. The danger is a plan that is never rechecked after the body changes. For example, a person may start medication at 70 when they weigh 180 pounds and eat salty restaurant food every day. 5 years later, they weigh 158 pounds, eat less, walk less, drink less, and take 3 new prescriptions. The same dose may have a stronger effect than it used to. Another person may be hospitalized, discharged on additional medication, and never have the full list simplified afterward. Another may take a diuretic in the morning and feel dizzy every time they stand after breakfast. These are solvable problems, but only if someone looks. This is where pharmacists can be extremely helpful. A pharmacist can review timing, duplicate effects, interactions, and side effects. They can identify medicines that may contribute to dizziness or falls and communicate concerns to your doctor. If you have more than 5 regular medications, a structured medication review is not a luxury. It is part of fall prevention. This is especially important for people taking multiple drugs. The more medication someone takes, the higher the chance of interactions, duplicate effects, and side effects that look like aging. Dizziness, confusion, constipation, weakness, urinary problems, and sleepiness are often treated as separate problems when they may be connected to the medication list. That does not mean medications are bad. It means they deserve review. Ask your doctor or pharmacist for a medication review at least once a year, and sooner if you have falls, dizziness, hospitalizations, or major health changes. Ask which medicines lower blood pressure, which affect balance, and which might be reduced safely if appropriate. Again, never do this alone. Now I want to return to the emotional part of this, because it matters. Many older adults blame themselves. They say, I am just getting old. They stop walking because they feel unsafe. They stop going out because they fear falling. They stop trusting their legs. Their world becomes smaller. And nobody checks whether the blood pressure plan is part of the problem. That is heartbreaking because sometimes the solution is not dramatic. Sometimes it is as simple as measuring standing pressure, adjusting medication timing, treating dehydration, reviewing a diuretic, improving breakfast, correcting anemia, or changing a dose under medical supervision. A small adjustment can give a person back confidence. Not always, not for everyone, but often enough that the question must be asked. So here is your action plan for this week. Step 1, observe your symptoms. Do not dismiss them. Write down when dizziness, fogginess, weakness, or near falls happen. Step 2. Measure wisely. Take blood pressure sitting or lying, and again after standing following safe instructions. Record the numbers and symptoms. Step 3. Review medication timing. Do not change anything, but write down what you take and when you take it. Step 4. Schedule a conversation with your doctor if you notice drops, symptoms, falls, or numbers that concern you. Step 5. Ask directly for your individualized blood pressure target, not a generic target. These steps are simple, but they can change the quality of the appointment. Instead of walking in with fear, you walk in with data. Instead of saying, "I feel off," you say, "Here are my readings, here are my symptoms, and here is when they happen." I also want to mention something many families overlook: cognitive symptoms. When an older parent becomes foggy, slow, or less sharp, the family often fears dementia immediately. Sometimes that fear is valid and needs evaluation. But cognition is influenced by sleep, infection, dehydration, thyroid problems, vitamin deficiencies, depression, hearing loss, medication effects, and circulation. A person who is repeatedly lightheaded when standing may also feel mentally dull because the brain is not being supported consistently. Do not jump to conclusions, but do not ignore the symptom either. If thinking changes appeared around the same time as dizziness, falls, blood pressure changes, or medication changes, tell the clinician. That timeline matters. Mom is getting confused is less useful than Mom became more confused after her blood pressure medication was increased, and her standing readings are much lower than her sitting readings. The second sentence gives the doctor something to investigate. Safety during testing matters. If you have already fainted, fallen recently, or feel severely unsteady, do not perform standing measurements alone. Ask a family member to help or request the test in a clinic. Keep a chair behind you. Do not rush. Do not walk away while the cuff is inflating. If you develop chest pain, severe shortness of breath, one-sided weakness, trouble speaking, or new confusion, that is not a home monitoring situation. That is urgent medical care. Also make sure your monitor fits your arm correctly. A cuff that is too small can read falsely high. A cuff that is too large can read falsely low. Rest your arm at heart level. Keep your feet flat if sitting. Avoid measuring right after caffeine, exercise, nicotine, or stress unless your doctor specifically wants to know that response. Good data depends on good technique. That is how you become an informed patient, and informed patients are safer patients. Before we close, let me repeat the central message. 120/80 is not automatically wrong, and it is not automatically right. It is a number that must be interpreted in context. For some older adults, lower targets may be beneficial and well tolerated. For others, especially those with dizziness, frailty, falls, or medication side effects, the safest plan may look different. Your doctor's job is not to chase the prettiest number. Your doctor's job is to help you reduce risk while preserving function, balance, thinking, and independence. Your job is to report what is happening outside the clinic. Because your life does not happen in the exam chair. It happens when you stand up from bed. It happens when you walk to the bathroom at night. It happens when you carry groceries, climb steps, take a shower, garden, cook, and move through your home. A blood pressure plan should protect that life. So if you have been told your pressure is perfect, but your body feels worse, do not panic and do not rebel against your treatment. Ask better questions. Measure the right moments. Bring your doctor real information. Work together. That conversation may protect your heart, your brain, your balance, and your independence. If this message helped you, share it with someone over 65 who takes blood pressure medication or has dizziness when standing. It may give them the courage to ask the question they have been avoiding. And remember, this video is educational. It cannot diagnose your symptoms or tell you what your blood pressure target should be. Your personal medical history, kidney function, heart health, stroke history, diabetes status, medications, and fall risk all matter. Use this information to speak with a qualified healthcare professional before making changes. Your number matters, but how you feel, how you stand, how you walk, and how safely blood reaches your brain matter too. I am Dr. Richard Ben. Stay aware, stay steady, and I will see you in the next video.